Good morning, everybody. I'll be talking about drug options in uveitis. My talk is mainly pitched for general ophthalmologists, comprehensive ophthalmologists, and retina specialists who are interested in treating uveitis. Corticosteroids became available for first use in human beings in 1949, and it was first used in 1950 in New York by Dr. Gordon, and it changed the world. In spite of that, prevalence of visual disability in ocular inflammatory disorders remains high. But corticosteroids remain the cornerstone for uveitis therapy, acutely in any inflammation, most particularly in vision-threatening uveitis. But they always produce trouble if used repeatedly or chronically. Rheumatologists learned their lessons long ago and the hard way. They began to use steroids and NSAIDs first, reserving immunotherapy for patients with advanced disease that resulted in progressive joint damage and more disability. They began exploring the option of using immunosuppressives in early course of disease, and they found better outcome in vast majority of patients with lesser disability and also lesser toxicity as well. We can and should also learn from them. We should embrace this model of steroid-sparing, remission-inducing therapy with even more vigor than does rheumatology, since the eye is so much less forgiving for chronic inflammation than the joint, with profound life-altering consequences. So, the proposed model for care in uveitis is first make the diagnosis. We do not want to treat patients with syphilis, syphilitic uveitis, or other infectious uveitis with immunosuppressives. And if you are unsure, if you are not sure, refer. Refer if the disease is chronic, it is relapsing. Refer the patient to someone who does uveitis routinely. Actually, this talk is mainly pitched predominantly to comprehensive ophthalmologists. If you find that this patient needs immunomodulatory therapy, and if you are comfortable with it, start it. And if you like to treat and learn, partner with a rheumatologist. General principle of treatment are shown here. Abolish the infectious disease. If you see a unilateral recurrent non-granulomatous anterior uveitis with transmyelination defects, the patient does not require steroids. It requires systemic acyclovir therapy. There is nothing like steroids. Nothing comes close to steroids in controlling the inflammation. Use it as much to control the inflammation quickly before the vision is damaged. Topical non-steroidal drugs have no role, but there is evidence that systemic NSAID therapy is especially effective in preventing recurrences of inflammation in idiopathic and HLA-B27 associated uveitis. Now, coming to the steroid-sparing immunomodulatory therapy, these are the guidelines suggested by International Uveitis Study Group, IUSG, many years ago. These are the conditions where the uveitis is associated with potentially life-threatening condition. So here you start the immunomodulatory therapy is mandatory. IUSG also suggests that certain diseases where long-term outcome with the steroids alone are poor should be treated with IMT from the very beginning. And finally, uveitis study group felt that there are certain kind of cases where it is prudent, not mandatory, to educate the patient about the need of IMT if the disease is chronic and is recurrent. JIA in particular. So, the therapeutic principles are listed below. Preserve the function. If macula and visual function has already gone, there is no point in starting IMT. Calculate the risk-benefit ratio. With anterior non-granulomatous uveitis, you do not need cyclophosphamide. Understand the diagnosis. Patients with herpes or syphilis do not need IMT. Use a step-ladder approach in aggressiveness to care. Use a chemotherapist or rheumatologist if you are not comfortable. use enough and soon enough. So here is a list of immunomodulatory drugs, and here are some of them. They will look new to you. And it is always advised to take help and partner with a uveitis specialist who is doing uveitis day and out, and or a chemotherapist or a rheumatologist when you need to use these drugs. American Uveitis Society Consensus Panel came out with the conclusion that there is good evidence of appropriateness of steroid-sparing immunosuppressive therapy. They also suggested that this concept should be propagated amongst the ophthalmologists, among the people who are dealing with uveitis. There are two main fears in the mind of ophthalmologists about these immunosuppressives: the risk of neoplasia, their toxicity and side effects. See, this study conducted by Dr. Stephen Foster, they studied 160 patients on methotrexate for about 5 years, and this was the problem. Are they really a problem? Serious enough? They can be effectively checked and reversed with proper monitoring and stoppage of drug at the right time. It is shown that the prevalence of malignancy in patients with IMT is no higher than the general population except in alkylating agents. Cite systemic immunosuppressive therapy has shown this. Systemic immunosuppressive study has shown this. In 543 patients, there were only 5 malignancies, and there were only 2 patients with systemic disease, like with risk factors, and 3 patients without the risk factors. So this all we know, but we do not. What is not known is the duration of therapy, and when is the durable remission achieved to discontinue the therapy. All patients who need IMT, baseline investigations and routine monitoring is necessary. You need to do a CBC, LFT, very important. LFT is very important. You need to do a complete metabolic panel, and TPMT activity is important in azathioprine, though this test is now available in India. Patients who are in childbearing age, we must consider the risk. There are drugs which can be used in pregnancy, like corticosteroids, azathioprine, TNF inhibitors. They can be used in pregnancy, and these are the drugs, cyclophosphamide, methotrexate, and mycophenolate, we should avoid. Now, coming to the most common antimetabolites that is used is methotrexate. Methotrexate can be given by either oral, IV, or subcutaneous route. The subcutaneous injection has greater bioavailability than the oral route, and there are lesser GI irritation than oral administration. The CITE study shows that at the completion of 1 year, there is 66% of patients there was no infection, and in 58% patient it showed steroid sparing effect. So it is an effective drug. Because of its, it can be very safely used in children because there is no long-term risk of neoplasia. Elevation of Lear enzyme can happen, but you can do monitoring with these patients. Use folic acid along with the methotrexate. Avoid alcohol, and appropriate contraceptive advice is important in childbearing age patients. Azathioprine is another common immunosuppressive that is used. It is an effective drug with 62. CITE study showed 62% effectivity in controlling the infection at 1 year, and 47% patients achieved steroid sparing effect with azathioprine. If the patient is, this is important here, if the patient is positive for TPMT, inherited thiopurine methyltransferase enzyme, then there are more chances of developing leukopenia and suppression of cell development. So if this test is positive in these in patients, one should avoid using immunon if the TPMT is positive. This test was not available earlier in India, but now it is available, and this can be performed here. The usual doses are between 100 to 200 milligrams per day. The common complex complication which can occur is leukopenia, but if you are monitoring the disease, you can very well check whether it is developing. Elevation of liver enzyme can also be very easily monitored. Mycophenolate is a favorite of modern antimetabolites because of its nice side effect profile, and it is very rapidly effective. The dosage is 100 to 1500 milligrams twice daily. The most common complication side effect that occurs with this is GI disturbance, that is seen in about 18% of the patient, and it is a very robust data that shows on site study that shows 73% patient had no inflammation at 1 year, and 55% showed steroid sparing effect at the completion with this mycophenolate. I'll skip these few drugs because they are not very commonly used in ophthalmic practice. Now coming to just the introduction of biological response modifier. Biological response modifiers are proteins produced by recombinant DNA or monoclonal antibody technology designed to block specific mediators of cell-mediated immune response. Most uveitis specialists, I'll not say all, would not manage the administration of these drugs on their own and would prefer to refer the patient to a rheumatologist. They are used off-label in ophthalmology, and it is very important that we should be sure that there is no infection, the disease is not infectious. The rationale for using biological response modifier is based on scientific evidence. Dosing, duration of therapy, and the choice of agent is mostly empirical. TNF-alpha block inhibitors are the commonest used biological response inhibitors. The most common is infliximab and adalimumab, and they have been approved for Behçet's and other uveitis, and they have shown efficacy in various studies. The most common complication and serious problem with these is exacerbation of demyelinating disease. They may develop congestive heart failure. Tuberculosis, if latent, can get exacerbated. Drug-induced lupus and neoplasia, risk of neoplasia is also there. Rituximab is efficacious in refractory scleritis, systemic vasculitis, and pediatric uveitis. There may be complications like profound lymphopenia, hypersensitivity reaction, and infusion reactions like they can occur in other biological response drugs also. Now, in summary, follow the treatment paradigm. Early institution of chemotherapy, immunomodulatory therapy, is the most in the most serious diseases. Therapy requires vigilance and lab monitoring. Therapy may be required for years, and it is very important to counsel the patient about these drugs, because in our scenario, patient does not understand the seriousness of the disease as well as the seriousness of this treatment. So we have to inform this patient that the treatment has some side effects. You must be aware of it. You must come for regular monitoring, and the treatment will require a long time. Thank you.